Second-generation integrase inhibitors are currently recommended as first-line therapy and have been recently introduced in Russian Federation countries. The study aimed to evaluate the in vitro susceptibility to integrase inhibitors in viral strains belonging to subtype A6, which is the most prevalent HIV-1 genetic variant circulating in Russian Federation countries. Among 81 sequences stored in the Italian ORCA database assigned to subtype A by sequence homology, we identified 20 sequences belonging to subtype A6 through phylogenetic analysis, including A6 reference sequences retrieved from Los Alamos National Laboratory HIV-1 database. Based on plasma sample availability, we created 15 NL43-based recombinant viruses harboring patient-derived A6 integrase coding region. None of the viruses include major integrase-resistant associated mutation, and all but one viruses had the L74I variant, which is the consensus amino acid in sequences belonging to subtype A. We determined the phenotypic susceptibility to dolutegravir, bictegravir, and cabotegravir, and we found that all the viruses had IC50 value comparable to that of the wild-type NL43 virus. 6 out of 15 samples show fold change values slightly higher than the biological fold change cutoff for dolutegravir, indicating a possible minimal reduction in dolutegravir susceptibility. In conclusion, we found that subtype A6 accounted for nearly 25% of sequences previously assigned to subtype A by sequence homology. All the samples considered in this study were susceptible to integrase inhibitors, with a possible reduced susceptibility to dolutegravir in few cases. This data suggests that the susceptibility to integrase inhibitors does not differ from that of subtype B. However, further studies will be carried out to evaluate the genetic barrier to resistance to integrase inhibitors in subtype A6 viruses. The study is based upon work from CARE Consortium that has received funding from the European Union's Horizon 2020 Research and Innovation Programme.
Doravirin is a recently approved HIV-1 non-nucleoside reverse transcriptase inhibitor showing full activity against most single NNRTI mutations and clinically relevant combinations of NNRTI mutations. Previous studies demonstrated that doravirin has a partially overlapping resistance profile as compared to rilpivirine and detravirin. However, a significant cross-resistance has been observed in clones harboring multiple NNRTI mutations. Considering the possible use of doravirin in salvage therapy, we aimed to evaluate the susceptibility to doravirin and the residual activity of etravirin and rilpivirine in multi-drug resistance HIV-1 isolate. 22 plasma samples were collected at virological failure from patients infected by 4 drug class resistant HIV-1. We identified major doravirin resistance associated mutations according to IAS USA mutations list and Stanford HIV drug resistance database. We generated recombinant viruses expressing clinically derived protease and reverse transcriptase coding region, and we measured the in vitro susceptibility to doravirin, rilpivirine, and etravirin. We also compared genotypic and phenotypic susceptibility data according to Stanford prediction algorithm. As indicated in Figure A, median fold change values for doravirin, etravirin, and rilpivirine were 9.8, 42.9, and 100 respectively. At sample collection, 10 patients were receiving etravirin and 1 patient was receiving rilpivirine, while 9, 5, and 8 patients had been exposed to 1, 2, and 3 NNRTIs, respectively. As indicated in Figure B, fold change values were higher in patients exposed to NNRTI at sample collection, with statistical significance for Doravirin and Rilpivirine. According to Stanford HIV database and IAS USA list, major Doravirin resistant associated mutation were found in 4 sequences in both cases. Fold change values calculated with Doravirin were significantly higher in sample harboring Doravirin mutations as compared to sample without Doravirin mutations. By comparing genotypic and phenotypic data, emerged that Doravirin activity was underestimated by genotype in 9 cases. According to the biological or clinical fold change cutoff values, residual susceptibility was observed in 5 cases for Doravirin, 4 cases for Etravirin, and 1 case for Rilpivirine, while additional 3 samples had partial susceptibility to Etravirin. In conclusion, in these studies, multi-drug resistant HIV-1 have limited residual susceptibility to NNRTIs. Doravirin retained full activity on a limited number of viruses, indicating cross-resistance with mutations selected by older NNRTIs. In addition, susceptibility to Doravirin may be affected by NNRTI exposure at virological failure. We found that the Doravirin activity was underestimated by genotype in nearly half of the cases.
Good afternoon, everyone. My name is Nadine Lübke from the Institute of Virology in Düsseldorf, Germany, and I would like to present you my poster with the title Two-Drug Regimen for Initial HIV Treatment, Lessons Learned from 20 Years Resigner Cohort. The Resigner study was initiated in 1999 in Germany with a total of 38 participating HIV treatment centers in North Rhine-Westphalia for the surveillance of transmitted drug resistance. We currently have access to virological and clinical data from 20 years of documentation. Our objectives were to screen for baseline drug resistance mutations affecting the use of Dovato in first-line treatment and to analyze differences in time to viral suppression of 2DR versus 3DR in the Resigner cohort, depending on the used drug classes. When we take a short look at the characteristics of the cohort, we see that in total 4,815 patients were included, with a majority of men. Overall, 4,219 documented therapies were available, with 4,203 corresponding sequence data. When we look at the baseline viral loads, we see that they were stable over time, with about 60% of patients presenting viral loads below 100,000 copies, and only about 10% of patients with viral loads greater than 500,000 copies per ml. But when we look at the baseline CD4 cell counts, we find a stable decrease of CD4 cells below 200 at the time point of therapy initiation, which clearly reflects the development of the earlier start of therapy in the recent years. A significant decrease is also found when we look at the prevalence of the M184V. While we found this mutation in 60% of the sequences in 1999, the prevalence has dropped to only 15% in 2019. Overall, the prevalence of the M184V at baseline is really rare, with less than 0.5%. Also, the prevalence of integrase inhibitor drug resistance mutations at baseline is very low, with less than 1%. We also looked at the differences in time to viral suppression. First, we looked at differences between 3DR therapies, where we found significant differences between different drug classes. Integrase inhibitor-based therapies showed significantly faster decreases in viral load after therapy initiation compared to NNRTI or PI-based therapies, whereas the comparison between the documented 2DR and 3DR therapies presented no significant differences. In conclusion, baseline resistance to 3-TC/FTC or integrase inhibitors was only were detected in our cohort. And integrase inhibitor-based therapies showed significant faster time to viral suppression compared to NNRTI or PI-based therapies. Although only few baseline 2DR therapies were documented yet, inferiority to 3DR could not be detected. A 2DR regimen as Dovato could be considered as alternative option for initial HIV treatment. And finally, I want to thank my colleagues in my institute and also all cooperation partners and participating HIV treatment centers, and of course you for your attention.